Pain management is a cornerstone of modern healthcare, addressing a deeply personal and universal human experience. Pain is not just a physical sensation, it also involves emotional and psychological components. The International Association for the Study of Pain defines pain as an unpleasant sensory and emotional experience related to actual or potential tissue damage. This complexity means that effective pain management must consider both the body and mind. Opioids have played a central role in treating moderate to severe pain, especially in acute, surgical, and cancer-related cases. However, their use is accompanied by significant concerns about safety, dependence, and misuse. In this video, we'll explore the clinical benefits, risks, and evolving strategies for optimizing opioid use in pain management. Pain affects more than one-third of the global population, with chronic pain impacting nearly 10% of people each year. In Europe, about 20% of adults live with chronic pain, placing a heavy burden on healthcare systems and economies. Despite advances in pain management, millions still suffer from untreated pain, especially in low- and middle-income countries where access to opioid analgesia is limited. Conversely, in some high-income countries, excessive opioid prescribing has led to crises of misuse and overdose. These contrasting realities highlight the ongoing challenge of ensuring appropriate access to pain relief while minimizing risks. Opioids remain essential agents for managing moderate to severe pain, especially in anesthesia, critical care, and palliative medicine. Their introduction revolutionized the treatment of acute surgical pain, trauma, and cancer-related pain. However, their benefits come with significant safety concerns, including the risk of dependence, tolerance, and misuse. The opioid crisis in the United States is a stark reminder of the dangers of overprescription and inadequate monitoring. Meanwhile, regulatory barriers and misinformation in other regions leave many patients without adequate pain relief. Balancing these issues is a key focus for clinicians and policymakers. To provide a comprehensive overview, a narrative review was conducted, synthesizing evidence from clinical trials, guidelines, and policy documents. The review covered opioid mechanisms, clinical indications, risks, and strategies for safer, individualized use. Sources included major medical databases and authoritative organizations like the WHO and CDC. Evidence was graded using the GRADE framework, ensuring recommendations reflect the balance of benefits and harms. This approach supports clinicians in making informed, patient-centered decisions about opioid prescribing. Pain is a complex phenomenon with several types: nociceptive, neuropathic, inflammatory, and functional. Each type involves different mechanisms and requires tailored management. For example, nociplastic pain is characterized by altered central processing and often responds poorly to opioids. The pain experience involves transduction, transmission, modulation, and perception, with both physiological and psychological factors at play. Chronic pain conditions can result from persistent sensitization of pain pathways, making management particularly challenging. Opioids exert their analgesic effects by binding to specific receptors in the nervous system: mu, delta, kappa, and nociceptin receptors. These receptors are widely distributed in pain pathways. When activated, they reduce neural excitability and inhibit neurotransmitter release, dampening pain signals. Exogenous opioids mimic the body's natural pain-relieving peptides, but their effectiveness and side effects can vary based on genetics, metabolism, and drug interaction. Understanding these mechanisms is crucial for optimizing opioid therapy and minimizing risks. World Health Organization's analgesic ladder, introduced in 1986, provided a stepwise approach to cancer pain management. It emphasized escalating from non-opioid treatments to stronger opioids as needed. While this model improved global understanding, it has limitations, such as inconsistent implementation and the need to incorporate newer therapies. Modern pain management now tailors treatment to pain severity and type, using multimodal strategies that combine pharmacological and non-pharmacological approaches. Acute pain lasting less than a month is best managed with non-opioid therapies like paracetamol and NSAIDs as first-line treatments. Opioids are reserved for severe pain or when other treatments are ineffective or contraindicated. Guidelines recommend a step-down approach. Start with strong opioids for severe pain, then transition to weaker opioids and non-opioid options as pain subsides. Immediate-release opioids are preferred for acute pain to reduce overdose risk and allow safer dose control. Managing acute pain involves assessing pain type, location, and severity using validated scales. The approach starts with non-pharmacological methods, then progresses to paracetamol or NSAIDs for mild pain, inhaled analgesics for moderate pain, and intravenous opioids for severe pain. Careful titration and monitoring are essential to minimize risks like sedation and respiratory depression. Advent treatments and regular reassessment help ensure effective and safe pain control. Prescribing opioids for acute pain, clinicians must closely monitor patient responses, balancing pain relief with risks such as sedation, respiratory depression, and dependency. Intravenous opioids should not be used together, and emergency antidotes like naloxone must be available. Dosages should be carefully calculated, especially when combined with other sedatives, to prevent serious adverse effects. Regular follow-ups are crucial to assess effectiveness and minimize risk. Opioids play a complex role in chronic pain management. While they are crucial for severe pain, especially when access to specialized pain clinics is limited, their use requires ongoing evaluation due to risks of side effects and addiction. Dosage should be adjusted gradually, considering pain type, intensity, and patient health. Prompt pain relief should not be delayed, but clinicians must avoid harmful effects on daily activities and psychological well-being. Use of opioids for chronic non-cancer pain is controversial due to limited long-term efficacy and safety concerns. Guidelines recommend prioritizing non-opioid therapies, especially for patients with a history of substance use or psychiatric conditions. Opioids should be reserved for cases where pain persists despite optimized treatments, and doses should not exceed 59 mg morphine equivalents daily. Regular monitoring and individualized adjustments are essential. Cancer pain, weak opioids like tramadol and codeine are often used for mild to moderate pain, but may be insufficient for many patients. Strong opioids such as morphine, oxycodone, and fentanyl are recommended for severe pain, with over 90% of patients achieving significant relief within 2 weeks. However, side effects like constipation and nausea are common, requiring careful management and regular reassessment. For moderate pain, medications like tramadol or codeine can be started, while severe pain calls for strong opioids such as morphine or oxycodone. Dosing should begin with immediate release formulations, adjusting to extended release as needed. Rescue doses are calculated based on total daily intake. Regular reassessment every 8-12 weeks ensures ongoing safety and effectiveness, with dose reductions or therapy changes as necessary. Breakthrough cancer pain requires rapid-acting rescue opioids tailored to the pain's onset and duration. Transmucosal fentanyl formulations are preferred for rapid onset episodes, while immediate-release morphine or oxycodone is suitable for slower or predictable pain. Individual titration is key, and different fentanyl formulations offer varying absorption rates to match patient needs. Neuropathic pain, caused by nerve damage or dysfunction, is often resistant to conventional analgesics. Opioids may provide some relief but are generally less effective than anticonvulsants or certain antidepressants. Side effects are more pronounced, leading to high discontinuation rates. Opioids are reserved for refractory cases with careful dose titration and monitoring to minimize risks. Management of neuropathic pain prioritizes non-opioid treatments like tricyclic antidepressants, SNRIs, and gabapentinoids. Opioids such as tramadol are second-line options, reserved for cases where first-line therapies fail. Strong opioids are considered only after neurostimulation and are used with caution. Combination therapy may enhance pain relief but increases the risk of side effects, requiring close monitoring. Conditions like fibromyalgia, chronic low back pain, visceral pain, and chronic headaches, opioids are generally not recommended due to limited efficacy and high risk of harm. Non-opioid options such as antidepressants and physical rehabilitation are preferred. In osteoarthritis, NSAIDs outperform opioids for pain and function with fewer adverse effects. Opioids may be considered only for short-term use in specific cases. Newer opioid therapies like tapentadol and buprenorphine offer promising alternatives. Tapentadol combines opioid receptor agonism with noradrenaline reuptake inhibition, making it suitable for neuropathic and mixed pain states. Buprenorphine, a partial agonist, is increasingly used in chronic pain, especially for patients at high risk of adverse events. Both agents require careful patient selection and monitoring to maximize benefits and minimize risk. Nebulized opioids are an emerging off-label option for symptom control when oral or injectable routes are not feasible, especially in palliative care. While modern aerosol devices may improve drug delivery, clinical benefits remain inconsistent and more research is needed. Careful patient selection and monitoring are essential when considering this approach. Long-term opioid therapy carries significant risks, including abuse, misuse, dependence, and overdose. While opioids provide short-term pain relief, their long-term benefits are modest, and side effects like nausea, dizziness, and constipation are common. High doses and prolonged use increase the risk of fatal overdose, especially with synthetic opioids. Regular monitoring and risk mitigation strategies are essential for safe opioid prescribing. Opioid-induced hyperalgesia, OIH, is a phenomenon where patients become more sensitive to pain as a result of opioid therapy. This affects up to 39% of patients and complicates pain management. OIH often leads to increased opioid doses, worsening the problem. Recognizing and addressing OIH is crucial for optimizing pain control and minimizing harm. Opioid rotation involves switching between different opioids or routes of administration to improve pain control and reduce side effects. While no single opioid is universally superior, rotation can help manage tolerance, opioid-induced hyperalgesia, and poor side effect profiles. Methadone, with its unique properties, is particularly effective in refractory cases, but requires careful dosing and monitoring. Literature uses various terms to describe problematic opioid use, including misuse, abuse, and addiction. Misuse refers to use contrary to prescription, abuse is intentional non-medical use, and addiction is compulsive use despite harm. These distinctions are important for understanding prevalence and guiding clinical management, though many studies use the terms interchangeably. Estimates of opioid misuse and dependence vary widely, from less than 1% to over 30% depending on definitions and study methods. Misuse is the most commonly reported issue, with prevalence influenced by clinical practices, dosage, treatment duration, and socioeconomic factors. While dependence rates are lower in patients without prior substance use, high doses and long-term use increase the risk. Opioid dependence is influenced by genetic, social, and individual factors. Genetic variations affect drug metabolism and susceptibility to dependence. Racial disparities in prescribing practices lead to unequal access and outcomes, with Black patients often receiving fewer opioids for similar conditions. Socioeconomic status, mental health, and family history also play significant roles in addiction risk. Certain groups are at higher risk for opioid dependence, including adolescents, older adults, individuals with mental illness, and those with a history of substance use. High opioid doses, long-term use, and concurrent benzodiazepine use further increase risk. Children of parents with opioid addiction face elevated risks for behavioral disorders and family disruption. Medication-assisted therapies, MATs, such as methadone and buprenorphine, are highly effective for treating opioid dependence, especially in non-cancer pain. These treatments reduce cravings, stabilize brain chemistry, and lower overdose risk. Despite lingering stigma, evidence supports their role in recovery and reducing opioid-related mortality. Combining MAT with psychological and educational support improves outcomes. Opioid tapering requires a structured, patient-centered approach. Gradual dose reduction, shared decision-making, and close monitoring help distinguish withdrawal symptoms from pain flares. Supportive measures including non-opioid analgesics, physical therapy, and psychological interventions can improve tolerability. Transitioning to buprenorphine may be safer for some patients during dose reduction. Despite evidence-based guidelines, real-world implementation of opioid prescribing and multimodal pain management is often limited by organizational and structural barriers. Time constraints, limited resources, and fragmented interdisciplinary collaboration hinder comprehensive care. Knowledge gaps among non-specialists and poor continuity of care after discharge further challenge effective pain management. There are significant global disparities in opioid access. While some countries face crises of overprescription and misuse, others struggle with regulatory barriers and limited availability, leaving millions with untreated pain. Addressing these disparities requires balanced policies that ensure access to essential analgesics while minimizing misuse and harm. Social conditions such as substance abuse, psychiatric disorders, and low socioeconomic status are key drivers of opioid dependence. Racial disparities in prescribing and access further complicate the landscape, with minority populations often receiving inadequate pain control. Addressing these determinants is essential for safer and more equitable pain management. Opioid therapy is associated with a range of adverse effects, including constipation, nausea, sedation, respiratory depression, hormonal imbalances, and cardiovascular issues. These complications can severely impact quality of life and often lead to discontinuation of therapy. Recognizing and managing side effects is a critical part of opioid prescribing. Opioid-induced hyperalgesia complicates pain management by increasing pain sensitivity in patients on long-term opioid therapy. This paradoxical effect can lead to escalating doses and worsening outcomes. Clinicians must be vigilant for signs of OIH and consider opioid rotation or alternative therapies when it occurs. Effective pain management requires a personalized, multimodal approach. This means combining pharmacological and non-pharmacological therapies, tailoring treatment plans to individual patient needs, and regularly reassessing risks and benefits. Patient-centered care improves outcomes and reduces the risk of long-term opioid dependence. Non-pharmacological therapies such as cognitive behavioral therapy, physical rehabilitation, and educational interventions are increasingly important in pain management. These approaches help reduce opioid dependence, improve functional outcomes, and address the psychological aspects of pain. Integrating these therapies into treatment plans is essential for comprehensive care. Advancements in opioid pharmacology, including novel agents like tapentadol and buprenorphine, offer new options with potentially fewer side effects. Ongoing research into alternative pain medications and non-opioid therapies holds promise for safer, more effective pain management. Future guidelines will likely emphasize individualized care and integrated approaches. Evidence supporting opioid use in pain management varies by condition and context. Strong recommendations exist for opioids in severe acute and cancer pain, while their use in chronic non-cancer pain is more limited and controversial. Multimodal strategies and risk management are strongly recommended to optimize outcomes and minimize harm. Health policies should promote equitable access to essential opioids while minimizing misuse through individualized prescribing, regular monitoring, and integration of non-pharmacological interventions. Reducing prescription bias and addressing disparities are critical for improving global pain care and ensuring that all patients receive appropriate treatment. Clinicians should prioritize patient-centered, multimodal approaches to pain management. Opioids should be reserved for clearly indicated situations and combined with non-pharmacological therapies to reduce long-term risks and improve functional outcomes. Regular reassessment and individualized risk mitigation are essential for safe and effective care. Implementing prescribing strategies that balance access and safety is crucial. This includes risk stratification, regular reassessment, and efforts to reduce social and racial disparities in opioid availability and pain treatment efficacy. Prescription drug monitoring programs, PDMPs, and screening tools help identify patients at risk for misuse or overdose. Significant knowledge gaps exist among healthcare providers regarding opioid use and pain management. Improving undergraduate and postgraduate training as well as ongoing education is essential to ensure safe, evidence-based prescribing and comprehensive patient care. Engaging patients in shared decision-making and providing support throughout their pain management journey improves adherence and outcomes. Educational interventions, self-management strategies, and regular follow-up empower patients to participate actively in their care and reduce reliance on opioids. Opioids remain indispensable for managing severe pain in selected conditions, but their use must be balanced against the risks of dependence, misuse, and adverse effects. Individualized, multimodal approaches, ongoing reassessment, and integration of non-pharmacological therapies are key to optimizing outcomes. Addressing social, racial, and policy barriers will help ensure safer and more equitable pain management for all. The future of pain management lies in continued research, innovation, and collaboration across disciplines. New therapies, improved education, and patient-centered policies will shape safer, more effective approaches to pain relief. By learning from past challenges and embracing integrated care, we can better address the complex needs of patients living with pain.